Over the next 10 minutes, I've been asked to speak on the Indian experience with heart transplants and LVADs. Currently, close to 230, 250 transplants are done every year in this country. And when we started the program more than a decade ago, we had to overcome several challenges. And the first was waitlist mortality, which is as high as 30% 10 years ago. And the commonest modality of mechanical circulatory support is ECMO because it's relatively inexpensive and easily available. And the first patient in India who had a bridge to transplant with ECMO was this lady with biventricular cardiomyopathy and creatinine of 2.8, who had a cardiac arrest, resuscitated on ECMO. And she was supported on ECMO for 2 weeks and then underwent a successful transplant. And 5 years later, she had a VO2 max of 30 and she could ski on the slopes of Gulmarg and physically climb Vaishnav Devi on foot. We've used ECMO extensively in pediatric patients. In children with biventricular cardiomyopathy, especially restricted cardiomyopathy, it might be better to do a sternotomy incision. This boy was on ECMO for 6 weeks. Finally, we got a donor organ which was dysfunctional and was refused by 9 units. But a dysfunctional heart from a much bigger and older donor actually can work in a child. And this child underwent a successful transplant. And this is him after 4 years doing well. One of the unsolved problems in India is we're not always able to do donor coronary angiograms. So sometimes we get coronary artery disease from the donor. This boy, the echo is on the left side, severe ventricular dysfunction. He got a donor heart after being in ECMO for 2 weeks, which was not great. And he underwent a transplant. He did very well initially with excellent biventricular function. But 3 weeks, he developed significant RV dysfunction. We took him to the cath lab. He had no rejection, but he had donor triple vessel disease, underwent stenting, and the RV function completely recovered. After 1 year, required restenting. He's alive and well after 5 years. We used impeller as well in a pediatric patient as a bridge to transplant. And the youngest VAD we have done successfully a transplant has been the age of 4. So over the last decade, we have done close to now 700 thoracic organ transplants, out of which 520 plus have been heart. 142 have been pediatric heart transplants. 18% of these patients have been on mechanical circulatory support. The youngest has been 4 months and the oldest has been 81 years of age. The 90-day survival has been 85%. And what are the hemodynamic factors which affect 90-day survival? The previous speaker spoke about Intermax. So low Intermax category of 1 and 2 has a significant risk on survival, as you can imagine, odds ratio of 0.59, and a poor renal function and a high creatinine more than 1.5 with an odds ratio of 2.02. As you can see, Intermax 1 and 2 has mortality of almost 27% 90 days as compared to 9% for Intermax 3. And so patients need to be referred in a more stable condition. And again, similarly, a preserved renal function, the survival is so much better as compared to impaired renal function. We have followed up these patients for up to 12 years. This is a Kaplan-Meier curve, a 12-year follow-up. 65% patients are alive and well at 12 years, which compares very favorably with what is published from the ISHLT data. For patients less than the 18 years of age, the outcomes even better, survival of close to 75%. Conditional 1-year survival for the whole group is 77%. If the age is more than 18, it's 73. But in children, actually, if they survive 1 year, over 90% can be expected to be alive at 10 years. And especially if you are presented with preserved renal function, a creatinine less than 1.5, and Intermax more than 1, close to 75% are alive at 10 years. Even within Intermax 1 and 2, there's a big difference. Intermax 1 are those patients who have had a cardiac arrest on a ECMO. Intermax 2 are still not had a cardiac arrest. As you can see, the difference is almost 25% at the end of 10 years. And even for patients with Intermax 1 who had a cardiac arrest and are massaged and put on ECMO and transplanted, if they survive the operation of the first 1 year, the long-term outcome is no different, and 50% are expected to be are alive at 10 years. The long-term risk for survival by Hazard-Cox regression is again poor renal function and low organ perfusion pressure, which is the difference between mean arterial pressure and CVP prior to transplantation. And this we published in the Journal of Heart and Circulation last year. As you can see, the impact of poor renal function on 10 years survival is dramatically highlighted by this figure, where patients with poor renal function have such a significantly poor outcome. So this again calls to question referral. End organ dysfunction is a major determinant of long-term survival. And in this country, we don't have a good listing criteria for combined heart and kidney. So patients need to be referred early before renal function is irreversibly damaged. This was published last year in the ISHLT. Rejection has been around 15%, but major rejection is life-threatening is not common. But increasingly, we see it at the end of 8 or 9 years. This girl, 9 years after transplant, presented to Holy Family Hospital, had near cardiac arrest, was massaged, put on ECMO. She was airlifted to our center. As you can see, this is her echo, barely noticeable contractility. A biopsy showed antibody made a rejection. She was put on rituximab, plasmapheresis, and immunoglobulin. And 10 days later, the ventricular function is completely recovered. She's now 2 years post-rejection. She's alive and well. The functional outcomes have been excellent. This man could run a marathon in an open field and finish first 5 years after transplant. And this girl in the foreground is playing tennis. This boy represents the soccer team for his state team. And this is an 84-year-old man, 1 year following a transplant, playing tennis in Besnagar Club. Our journey with LVADs, we were the first to implant HeartMate 2 in this country in the year 2012. The outcomes actually have been excellent, especially with HeartMate 3. This is the first man to undergo HeartMate 2 in India. As you can see, he's walking for the first time in almost 2 years. And 3 months later, he's recovered. And 1 year later, he became a grandfather. And 2 years later, he's back to eating and drinking with a punch. He survived for 9 years and eventually had a hemorrhage in the brain and succumbed. The longest surviving LVAD in India is this man. Now he's completed 12 years after LVAD. He's absolutely well. This was a HeartMate 2. 3 years after HeartMate 3, this patient is able to physically climb. He's had 2 previous surgeries, neonatal aortic valvotomy and Ross Corner procedure for aortic valve replacement. Presented with severe ventricular dysfunction. We put in a VAD. So he's able to physically climb the Raigad Fort, which is one of the most difficult forts to climb, even for normal people. As you can see, the steps are so steep, and he could do that with a VAD, with a battery and controller on his shoulder 3 months or in 3 years after a VAD. This man next to Anna Hazare, 3 months after HeartMate 3, he's physically normal, and he's playing volleyball on the forecourt. I'm not sure how advisable, this is the one hitting the ball. I'm not sure how advisable it is to jump around in a volleyball court because there's always a risk that he could trip and fall and put a tug on the drive line. And in the morning time, he's milking his cow. So when you design a VAD, it is not always only used in San Diego and people with yachts. It can be used in diverse settings, including countries like India where they are farmers. So this patient is living a normal life. A general surgeon with the previous CABG and recurrent VT unresponsive drugs is operating 5 cases a week after a VAD implant. And this patient with the previous 5 surgeries, including 2 double valve replacements with a hostile mediastinum, presented with severe biventricular dysfunction, ascites and deep jaundice and high creatinine. So we put in a VAD through a small left thoracotomy, and this is him after 4 months. He's alive and well after 9 years. Very briefly, when you say LVAD, it's not just one device. Different devices have different outcomes. Actually, we were using a lot of hardware in India because it was less expensive and smaller to insert. But a hardware pump had also a higher risk of stroke. So in the month of January this year, for some reason, by a matter of chance, we ended up doing 6 transplants in a week's time on patients with functioning VADs. As you can see, the hardware device, even after 8 years, the healing around the ventricular apex is poor as compared to the HeartMate 3 in the bottom, where the thing is completely endothelialized. So this is because of the centering of the inflow cannula, with, I think, amongst other things, is responsible for the better outcomes. The 5-year survival rate with HeartMate 3 now is approaching that of a transplant, close to over 50% are alive at 5 years. And the stroke rates are significantly less as compared to the axial pumps and the Medtronic HVAD. And hopefully those results will improve. In conclusion, excellent long-term outcomes are possible after heart transplant and LVADs, even in a country like ours with severe economic and financial constraints. We need more affordable VADs. I hope I finished in time. Thank you very much.